So secondary stimulation of hypocalcemia or secondary stimulation of parathyroid glands is secondary to hypocalcemia. So in most of these patients, we should have low calcium. Sometimes we do see normal calcium because that secondary stimulation resulting in higher PTH is causing that calcium to be normal. So PTH is high, and then again, same thing, we can have normal or increased phosphate depending on what etiology is happening. In renal failure patients, hyperphosphatemia is the main driving force for causing increased PTH. Tertiary, on the other hand, is a continuum of secondary in renal transplant patients or renal failure patients who have had renal failure for a long time. And this happens when the effect of hypocalcemia is lost due to persistent stimulation of the parathyroid glands, and there is autonomous hypersecretion of the parathyroid glands or parathyroid hormone, resulting in high PTH, high calcium, and obviously these patients are renal failure patients, so they have high phosphate. It troubles me a lot when people call secondary hyperparathyroidism as tertiary just because they have very high PTH. So important thing to understand is that even in secondary patients, there can be a very high PTH, and we do not like them to be called as tertiary until and unless they've had renal transplant and there is autonomous stimulation of these glands. Another slide very close to my heart. I love talking about this slide and I can spend hours on this slide. But I'm not going to discuss the slide here for now, but I wanted to show it because this actually shows the relevance of understanding pathophysiology in the management of secondary hyperparathyroidism. Each and every box here, I can talk about that where the medical management is indicated and when we need to intervene surgically. And this schematic diagram, I've taken it from Meyer's textbook, and this indicates what we see at the time of surgery, and very fascinating, interesting facts, and we can talk about it in another lecture on secondary hyperparathyroidism. Etiology, this slide I've included for completion's sake, but most common one is the single adenoma, the sporadic forms that we see and we like to see. We sometimes see double adenomas. We sometimes see multiglandular disease. And none of us is enthused about that multiglandular disease, but we occasionally, in 10 to 15% of the time, we encounter that. And then parathyroid carcinoma is extremely rare. And then there are some familial causes of primary hyperparathyroidism. Most of these familial patients present with multiglandular disease. Localization studies, as I mentioned earlier, this can be a lecture in itself. We can talk about a lot of localization studies, and localization studies are extremely important, especially for the surgeons. We all love to localize our parathyroid adenomas and then operate, and it is such a it's just so helpful to do surgery on the patients who have had a double localizing or a triple localizing adenomas. Most commonly used studies are ultrasound and Sestamibi, and in my practice, I use a combination of ultrasound and Sestamibi in every patient. Patient comes in, we do ultrasound and Sestamibi scan, Sestamibi with SPECT-CT on the same day, and then they see me, and then we plan on doing surgery. On ultrasound, parathyroid adenomas are seen as a hypoechoic lesions. They can be oval or elongated, and most of the time they have this nice artery, which is probably a branch of inferior thyroid artery, very well seen on the color Doppler. Some surgeons like to do their own ultrasound, and at some point in the beginning of my career, I was doing my own intraoperative or preoperative ultrasound right before making my incision. But over a period of time, we realized that we have great head and neck radiologists in our practice, so it was not worth the time. And obviously the bureaucracy and the politics of billing and all that. But yes, ultrasound is highly sensitive and specific for these. Another advantage is no radiation. You can also simultaneously see the thyroid disease and manage it if needed surgically. The downside is that you cannot see those mediastinally or the adenomas located in the mediastinum or deeply located adenomas. So for that, sometimes Sestamibi is helpful. So Sestamibi usually done with the SPECT-CT, and this picture I just added yesterday. Very interesting case, and we can discuss that later on if we have time. So this patient actually I just operated last month. She had, her ultrasound was negative, or I should say it was kind of missed. The adenoma was missed. It was a pretty big adenoma, but Sestamibi was localizing this adenoma in the carotid sheet. I don't know if you can see right here. Vagus was all stuck on this intraoperatively, but there was no way I could have found this adenoma or opened the carotid sheath unless I had known this on the SPECT-CT or Sestamibi. Sestamibi, basically, we inject technetium-99, or radiologist or nuclear medicine person injects technetium-99. And then early images are taken and delayed images are taken at 2 hours, early images at 15 minutes. And it captures that that the thyroid has an early washout of the contrast versus the parathyroid glands. It has delayed washout. Again, there can be some false negatives and false positives of Sestamibi, false positive and like Hashimoto's nodules of the thyroid, or false negative in those patients who have that parathyroid gland which are hyperfunctioning, but they have lower mitochondrial content and all that. And we can, it's all fascinating pathology that we can discuss, but yeah, there can be false positives and negatives in Sestamibi, and ultrasound is more sensitive in picking up these adenomas if done in the right hands. The last or another commonly, or not commonly, but another imaging modality that I use is a 4D CT scan. And I am very fortunate that in our practice, we have a radiologist who know how to read these and do these well. 4D CT scan, I usually use them for most of my revision cases or patients who have had surgery and they're non-localizing on ultrasound or Sestamibi. They are also helpful in localizing those missed one if they are negative on Sestamibi, but they're located in the mediastinum or deep in the neck or tracheoesophageal groove. This 4D CT actually combines the anatomic and physiologic details of the parathyroid adenomas. The fourth dimension actually is the change in enhancement over time from non-contrast images to arterial and the delayed venous phase imaging. And actually in these patients, the contrast enhanced pattern or the peak enhancement is in the arterial phase, as we can expect. In delayed phase, there is a washout of the contrast, and in the non-contrast images, we see low attenuation. Again, to do this and to read this, we need to have a radiologist who has experience in doing these. The rest of these images are rarely used these days. And then there are certain other things, the autofluorescence and other things, which are also coming along for intraoperative imaging. I want to take a moment here and stop for a second. If there are any questions or concerns, or if I'm not very clear on some of these slides, you're welcome to stop me and discuss. Okay, next we'll look at the classification, and rest of the slides will focus on the primary hyperparathyroidism, some of the guidelines and controversies related to the surgical management of different types of primary hyperparathyroidism. Let's look at the evolving indications of parathyroid surgery. Primary hyperparathyroidism, when it was first discovered about 80-90 years back, it was always symptomatic. Patients presented with hypercalcemia. They had symptoms of kidney stone, bone disease, abdominal pain, mood swings, and yada, yada. 40 years later, with the advent of autoanalyzers, the clinical phenotype of these patients or of this disorder actually changed to mild hypercalcemia in the absence of classic presentation with the symptoms. And now we are entering a third era in the history of the disease, in which we are now seeing some patients who are discovered with normal calcium, normal total and ionized calcium, but consistently elevated PTH. Essentially, all these three are different stages of same disease spectrum. This is again one of my favorite slides, this data is very helpful, and I would advise that we all should take this home today. This is very helpful when we are counseling the patients for surgery, and this is what patients want to know: how surgery is going to help them, and what will happen if they will, or how things are going to change if they undergo surgery, and what will happen if they do not undergo surgery. And this on the right side, this column actually indicates why we do what we do. We do surgery in the patients with symptomatic primary hyperparathyroidism because of that instant gratification and instant improvement in the patient's biochemical profile. Right away, 10 minutes after the removal of the adenoma, the parathyroid returns to normal. So there is return of improvement in the biochemical profile of these patients. I've quoted this, I've taken this data from this study, and this study quoted that there is improvement, or there is increase in bone mineral density of these patients, which is maximum in the post-op year 1. And then this improvement in the bone mineral density is sustained over a period of 10 to 15 years. And most of these patients don't have any recurrence of kidney stones over a decade. What happens in the patients who choose not to do surgery, or who have mild or asymptomatic presentation and they decide just to follow up? In most of these patients, biochemical abnormalities and the bone mineral disease can stay stable for 10 years, but then eventually there is a decline. So that decline means that they will have that end organ damage, and this is what we need to counsel the patients who decide to just do medical management or just to follow up, that eventually they will have an end organ damage. And once the end organ damage happens, then the improvement or the effects of surgery are there, but obviously there is no further deterioration, but the damage has already happened. So what do we know so far? Surgery is the only definite or curative therapy for primary hyperparathyroidism. The only consideration is the timing of surgery in the different stages of primary hyperparathyroidism. We all know that all symptomatic patients should undergo surgery. In asymptomatic patients, the indication for surgery is determined by other manifestations of primary hyperparathyroidism or patient preference. In normocalcemic patients, the data is limited, and our understanding of the disease is still evolving. And I'm going to quickly look at some of the guidelines in the management of asymptomatic and normocalcemic patients. In asymptomatic primary hyperparathyroidism, there are specific guidelines for the management and when we should intervene with surgery. These guidelines have been updated 4 times. The most recent one was in 2013. These guidelines take into account that surgical intervention in asymptomatic primary hyperparathyroidism patient in whom there is evidence of some subclinical end organ damage, or there is a risk of disease progression, then these patients should undergo surgery. So basically, these guidelines are based, or have evolved based on a thorough skeletal workup and the renal workup. So they have included that fact in these updated guidelines. Surgery is indicated if the calcium is above 1 above the normal range, or if there is evidence of bone mineral density being low after a thorough workup, or there is a renal dysfunction, presence of kidney stones on thorough workup with extensive imaging, or if the patient is young. We have to understand one fact, that the data supporting these guidelines for asymptomatic patients is very limited. There are some studies which have indicated that, again, that bone mineral density improves in these patients after parathyroidectomy, but there is definitely limited data or almost no data supporting or telling us the renal and cardiovascular improvement in these patients, or the neuropsychiatric or cognitive function in these patients, that in these asymptomatic patients eventually will it benefit in the cardiovascular and renal health. So this means that even if the patients don't meet the guidelines for surgery, then we can appropriately counsel them and tell them that the data is limited and there can be a benefit in protecting their end organs if we intervene or if they choose to decide surgery, as far as they have no medical contraindications. So all in all, we need better studies to support these guidelines if surgery is indicated in these patients with in asymptomatic primary hyperparathyroidism. These guidelines for asymptomatic patients also gave some guidelines, and which have also been updated, that patients who decide not to do surgery for asymptomatic, especially the asymptomatic ones, they should be monitored thoroughly, and we should closely follow up. And there comes the role of our endocrinology friends. They check the calcium every year, do the skeletal workup and the renal function based on these things, the biochemical profile and some of the imaging of the kidneys. Normal calcemic primary hyperparathyroidism probably represents the attenuated form of clinically symptomatic primary hyperparathyroidism. The true prevalence and the natural history and the clinical significance are mostly unknown in this disease. Again, very limited studies, very limited data, newly recognized entity in 2008. The diagnosis requires ruling out secondary hyperparathyroidism, as both these conditions can have normal calcium. So we have to make sure that these patients don't have renal insufficiency, they don't have hypercalciuria, their liver and no liver or GI disease. And most importantly, these patients, we have to make sure that the vitamin D levels are normal, within normal limits, or more than 30. And sometimes correcting these vitamin D levels also helps in unmasking those asymptomatic or asymptomatic primary hyperparathyroidism with elevated calcium. As I said, possibly a milder form of asymptomatic primary hyperparathyroidism. Limited data, one study has shown that at the time of diagnosis, about 50% of the patients can have bone disease, osteoporosis, fragility, fracture. Patients can become hypercalcemic during follow-up per the study. As far as the evolution of the disease process is concerned, again, you can see very, very limited data, not very good quality studies. One studies have shown that at the median follow-up of 1 year, some of these patients develop hypercalcemia. One study has shown that patients who did not undergo surgery did not develop hypercalcemia, but they did not evaluate other features. And then this study at median follow-up at 3 years has shown that patients who did not undergo management eventually became or showed the evidence of end organ damage in terms of fractures and osteoporosis and decreased bone mineral density and decreased renal function. Management-wise, again, little is known whether therapeutic intervention is aimed to normalize the PTH. May have long-term and short-term benefits. One study has shown that parathyroidectomy in these patients found a bone mineral density gain of 4% at some of the sites. So, do the guidelines for management of asymptomatic primary hyperparathyroidism apply to normal calcemic primary hyperparathyroidism? Answer is no. Follow-up versus early managements. Well, since not all patients have progression to hypercalcemic hyperparathyroidism state, and there are no markers of disease progression that are yet available, so decision regarding aggressive management versus follow-up should be individualized. And again, we need further research into the natural history of the disease. If we decide to intervene, should we intervene with medical management or surgical management? Surgery definitely sounds an attractive, conclusive management, but medical management can safeguard the end organ damage in these patients. We can give cinacalcet to improve calcium. We can give bisphosphonates to improve the bone density. We can do some thiazides for preventing the nephrolithiasis and those kind of things, which again our endocrinology colleagues can help us with. If we choose to do surgical management in these patients, unilateral versus bilateral exploration, unfortunately, most of these patients would present with multiglandular disease and non-localizing disease. And if surgery is chosen, we have to counsel the patients about the foregland exploration or bilateral exploration and the higher risks involved with that, and counsel the patients accordingly. Again, if these patients decide not to have any kind of intervention, since the calcium is normal, they have to be monitored closely. And if calcium and parathyroid hormone has to be checked annually, DEXA scan has to be done. If there is progression to hypercalcemic state, then we follow the guidelines. If they're asymptomatic, and if they are symptomatic, then we intervene with surgery. Quickly on symptomatic and some little bit about the surgery. Last but not the least, symptomatic primary hyperparathyroidism typically these days presents with incidental finding of hypercalcemia, and then in turn we see that, okay, they have all these symptoms of kidney stones, fatigue, depression, bone pain, gastric symptoms. And we all know that the cure for primary hyperparathyroidism in the symptomatic patients is removal of the source. Once we have bypassed the controversies on that, the technique and approach in these patients is all surgeon dependence and the experience of the surgeon. Bottom line is, whether we choose on unilateral exploration or bilateral exploration, this is the basic technique. We find the midline graft face, retract the strap muscles laterally, retract the thyroid medially, find our carotid artery, and then find that adenoma located right medial to the carotid artery or lateral to the thyroid lobe. So straightforward on both sides, whether unilateral or bilateral approach. Now, the next thing, this I like to share. I want to share this slide because I have shared this with some of the, I don't know if Dr. Harpreet and Dr. Monish are present in the audience, but I've shared this article with them. So this is a nice approach that was published several years ago. And I actually, early in my career, when I started doing it, and when I was doing my own ultrasounds right before making the incision, I used this approach and found it a nice tool to have. Basically, this is labeled as a lateral approach. I rarely use it for the straightforward primary cases. I mostly reserve this for the revision cases, and it may be a helpful approach in the revision cases because you are trying to avoid all that misery of separating the straps from the trachea and the thyroid when they're stuck down. In this approach, we come lateral to the strap muscles as opposed to this one in which we are coming medial to the strap muscles. So basically, we are aiming at the same area, medial to the carotid artery, but in this, we come lateral to the strap muscles, retract the strap muscles medially, retract the sternocleidomastoid muscle laterally, and retract the thyroid gland medially, and then look at that adenoma medial to the carotid artery. Again, this approach is only used if we can localize it on ultrasound or on one of the imaging studies. So it's a helpful approach. So we have moved from surgical exploration of all four glands in the past to the pre-op localization of the disease and minimally invasive surgery and a focused surgery. But this is not the end of the story. And I like to mention this article and I love talking about this article. And I know Dr. Serene has been trained in Florida. I don't know if he's familiar with the Norman group, and we can talk about that later. But Norman group from Florida is quite famous, or not so famous, I should say. They published this article and their experience in 15,000 parathyroid operations. And they suggested to abandon unilateral parathyroidectomy and just focus in all localizing or non-localizing patients, just focus on bilateral exploration. So interesting study, because 15,000 patients is a pretty big data. Anybody who does 15,000 operations can change the guidelines or change the approach. Well, but in this study, they have mentioned that unrecognized multiglandular disease can be seen in as high as 16% of the patients. And regardless of the surgical adjuncts or preoperative imaging, they suggested that their 1-year failure rate was about 5% and the 10-year recurrence rate was about 4 to 6%. And according to this graph, the cure rate was at its lowest when the unilateral operation rate was highest. But again, it was in the range of 5 to 6% failure. And they suggested that operative time, incision size, anesthesia, hospital stay, everything was identical, which obviously if you had done 15,000 operations, it's going to be similar. So what should be our go-to operation? Should we totally abandon minimally invasive surgery, which is a very low morbidity surgery, which gives us the virgin field for revision operations or other kind, revision operations in the neck? Interesting editorial, and I know we are a little bit over time, but I'm about to conclude it quickly because these are some interesting editorial articles I've included. What should we tell our patients? Lifetime guarantee, or is it a 5 to 10-year warranty on parathyroidectomy for primary hyperparathyroidism? Well, we need to see how far the pendulum has swung. Recurrence rate of 4 to 6% versus 1 to 2%. Not too different. We cannot still abandon the unilateral focused approach. But majority of us can do, if in a localizing disease, we can do it in 10 minutes, take out the adenoma. We rarely provide lifetime warranty of disease-free survival in medicine. In oncology world, we never tell the patients, or we rarely provide a lifetime warranty for the disease-free survival and informed consent for these patients. Why do we endocrine surgeons feel the need to give a lifetime guarantee to our operations? Orthopedic surgeons give a 5 to 10-year warranty for their joints and still consider it a success. So, instead of debating the superiority of the operation, we should actually identify the at-risk patients for long-term recurrence. I don't think that a 10-year warranty with bilateral operation is needed or required in an 80-year-old patient. Ideal operation is actually the one that can render the patient normocalcemic and asymptomatic with actually minimal morbidity eventually. So the take-home message, all patients with symptomatic primary hyperparathyroidism should get parathyroidectomy unless contraindicated. Patients with asymptomatic primary hyperparathyroidism should get parathyroidectomy if calcium levels are high or there is end organ damage or if the patient is young. And in normocalcemic patients, this entity may be an early form of primary hyperparathyroidism, and surgery may be indicated if there is accompanying end organ damage or imaging or labs. I think that's it. This is the clinic where I see patients here in Alabama.
Thank you so much, Garima. It's excellent as usual. I really liked your crisp take-home messages and especially the last few slides. I'm sure I will personally request Dr. Sareen, because he has much more experience than me personally on this topic, to take the audience questions also and take the discussion further in form of panel. Sareen sir, are you there?
Yeah, Kapil, I'm there. Thank you.
Yes. Sir, before you proceed, actually, most audience would like to know how most of these patients are presenting nowadays to us. Are they coming with, as Garima said, that history has evolved. Many of them, they used to present with bone pains and groans and what we had heard the previous symptoms. Is it still the same, or is it mainly the biochemical hypercalcemia that they are presenting with, and more practices for referral from other departments like endocrinology? Both to Garima and to you, sir.
So I have that covered as the intro to my panel, if it's okay.
Great, sir.
Once I started, I have 2-3 slides on it. In fact, I think it's an important changing.
I would request you also go through the audience questions also, sir, and put them to panelists.
I will put them. So let me see if I can start sharing the slides. Just give me a second. Right. Can everybody see my slides now?
Yeah, we can see it.
Okay. Wonderful. Thank you. Thank you, Dr. Taneja Vipin, for this opportunity, and a warm welcome to all the panelists and the audience who joined us. Garima, you said I trained in Florida. That's right. I trained at University of Miami with Irvine and Solorzano, from where the criteria for IOPTH came out. I hadn't heard of Norman then, but I can promise you there's no patient of PHPT in this world who's not heard of Norman, including in India. The moment they ask me, how long will you take for the parathyroid surgery? My answer is more than 16 minutes, because I'm not Norman. So anyway, with that, you beautifully encapsulated the disease, and it's nice that I can just put some questions beyond where you left off. To address what Kapil said, that that PHPT, or primary hyperparathyroidism, essentially was a renal and skeletal manifestations are the hallmark of this disease. But the US or the Western world has certainly seen a changing trend, with a large number of people being picked up with asymptomatic disease. And most of this is actually from two reasons. Number one, they fortified their milk with vitamin D many decades ago, and that took away some of the concomitant bone damage that would happen both with PHPT and vitamin D deficiency occurring together. But more importantly, as Garima said, when the autoanalyzers came up in the 70s and calcium screening measurements became fairly routine for people admitted for various reasons, you started picking up this disease very early in its course and asymptomatically. So they've really moved from as they say, a disease with symptoms to a disease in search of symptoms in the West. However, in India, you will still see patients with very dramatic presentations, both renal and, as you can see in this X-ray of a young girl we had, with massive skeletal manifestations. This trend, though, and again, you look at the biochemical parameters of disease in our country, it's a lot more severe biochemically as well than you generally see in the West, as in this comparative analysis. However, we published 7 years ago that asymptomatic disease is also now on the rise in our country. And of course, there may be a lot of bias based on where you practice, but certainly in tertiary care centers, we are starting to see asymptomatic disease, people with incidentally detected PHPT. And one of the things we looked at in our hospital was whether inclusion of routine calcium monitoring when we did a KFT affected this. And again, in this paper we published, we saw that if calcium, which cost 40 rupees extra to add to a kidney function panel test in our hospital, was added, the incidence of detection of PHPT for in-house patients really went up. So it again showing that if you start screening, you will find a lot more subclinical disease. I think with that intro, I'm going to start with the panel, and then we'll try and also take questions that may pop up in the chat box. I'll try and pause in between. Vipin had promised me 60 minutes for the panel, so I'm happy to go 60 or longer till everybody runs away, because it's such a fascinating topic. And as Garima said, that she loves the challenge. I'm a head neck surgeon. I love it because it's the only patient of mine who says, "Thank you, doctor, I feel better after your operation." All right, what I brought today are some case capsules and just some questions. I don't have a detailed case to discuss. These case capsules are virtual. Some are loosely based on real patients, but all of these are posing some problems that I think are vexing or worth listening to. And I would love to get our opinion of our panelists on it. So we have two surgeons. Garima, of course, we heard, and Saurabh is going to represent the Indian viewpoint. Saurabh is at Max. We have Dr. Madhu, who is the chief of endocrinology at UCMS and often forms a pivot for managing this disease. Ishita Sen, who's a nuclear medicine head at the Fortis Hospital in Gurgaon. And Dr. Alka Singhal, who's an ultrasonologist with us at Medanta and dedicated towards parathyroid and thyroid imaging. So my first question, Dr. Madhu, is in a patient who is suspected with primary hyperparathyroidism because of elevated calciums and elevated PTH, what's the basic workup that you would think all of us should do in a patient like this? For confirming the diagnosis and assessment of the extent of disease.
Yeah, thank you. And good morning and good evening to wherever you are. And you see, this is a basic starting point of getting to primary hyperparathyroidism. And if you have an elevated calcium and you've also done an elevated PTH, the one thing to remember is that the PTH should normally be concomitant or coexist just along with the calcium. It's not that you have to do a calcium on a different day and a elevated PTH on a different day. It could still be giving the same conclusion, but the ideal would be to do it simultaneously. So that's one. So I'm assuming that if you've done an elevated calcium and also you've done an elevated PTH, which is high on the same day, that would largely say it's a PTH dependent hypercalcemia. And once you have an elevated PTH dependent hypercalcemia, then barring a few exceptions, it is likely to be a PHPT. So you would require to do, in addition, many times, calcium excretion in the urine, because to rule out sometimes, especially in a younger patient, a familial FHH or familial hypocalciuric hypercalcemia. And for that, basically, you need to do a calcium clearance and go by the calcium excretion by a creatine excretion clearance ratio, and that would sort it out, because you will have low calcium levels in urine. In PHPT, you would have high calcium being excreted in the urine. And once that is out, for all practical purposes, you would come to a conclusion, at least in terms of an endocrine diagnosis, that this is all likelihood it is a PHPT. Of course, a vitamin D, sometimes not in a case like this generally, but a vitamin D level, it's useful to do in the workup just to be sure it's normal. It's more useful in patients whose calcium levels are closer to normal, or what we describe as a normal calcemic, but it's good to do a vitamin D as well in your workup. This would be the basic as far as the endocrine diagnosis is concerned. And once that is done, of course, we get on to imaging, and imaging has already been discussed in the talk. And in that sequence, you do an ultrasound or a Sestamibi and so on before you go for deciding whether or not to operate.
Okay, thank you. Just one or two follow-up questions. So when you said vitamin D is important when you have a patient with normal calcium and elevated PTHs, what value of vitamin D would you think would be sufficient to assume that this is not a secondary elevation of PTH from vitamin D deficiency? Like, what value would you consider sufficient?
Normally, a cutoff would be 30 nanogram per ml.
So above 30 should not be affecting your parathyroid levels to a meaningful degree.
Anything more than 30, we would consider that will not be affecting. Although in Indians, the situation is not exactly the same. It varies quite a bit, but this is the usual cutoff that we take.
Okay, excellent. Thank you. So I've got a couple of scenarios here. I think we've already covered this. If you could just very quickly run for me your thoughts on possible diagnosis. Assume these are all corrected calciums. Assume these patients have, so just assume this is all the information we have. So patient one has a normal calcium, but in the low normal range and elevated PTH. Is this likely to be PHPT, or what are the other causes we could look at?
What I said, in such a situation, the most important thing, especially in our country, is to do a vitamin D 25-hydroxy vitamin D level, and first make sure that the vitamin D levels are not low, because the calcium may be normalized despite a vitamin D deficiency, but the only thing you may find is a PTH which is elevated, and therefore I think secondary hyperparathyroidism is probably the first thing to consider. If that is normal, then you probably need to look at a few other rarer causes. Sometimes some drugs can cause such a scenario, and you need to look at some anticonvulsants. Although they may be working through vitamin D, they may be independent of vitamin D. Lithium, for example, is one. If somebody is on long-term lithium treatment, that could also have a scenario like this. And I think broadly the common ones are these, and sometimes you may have rare occasions. But the most important to rule out in our country would be a vitamin D deficiency and a secondary hyperpara to that. The second case scenario,
so
I think...
If you don't mind, I'll go to third first, because it's kind of similar to this. What are your thoughts on the third? Again, it's a normal calcium, but this time on the higher side of normal, and an elevated PTH.
Yes, this kind of a scenario is more suggestive of what could be a normocalcemic primary hyperparathyroidism. Although you cannot be 100% sure, you probably need to follow up. you need to repeat the values and see, because a low calcium or a low normal calcium, for it to be a primary hyperparathyroidism, is a little less common than a high normal calcium with a high PTH. So this scenario is a high normal calcium with a high PTH. And therefore, in this scenario, although at the moment you don't have a clear-cut hypercalcemia, these are the patients who would probably fit into the category more often or more likely into that normocalcemic HT scenario, and probably would require further workup or probably require a follow-up to see if they get into a hypercalcemic situation, assuming all of them are asymptomatic.
Okay. And what about patient 3 who has an elevated calcium but a PTH in the normal but on the higher side?
This is a second case scenario you're saying.
That's right.
Yeah, this is although it is a normal PTH, the classical thing that we find in a primary hyperparathyroidism, of course, is a calcium value similar to this and a PTH which is clearly elevated, maybe like the first and third case or even more. But in this case, while it is a normal PTH, it still is a high normal PTH, and this is an inappropriately normal, because for a high calcium we expect a suppressed PTH. And when we say suppressed, we normally would find a PTH less than 25. So if it is 60 with a calcium of 11.3, we should still consider it as a case of primary hyperparathyroidism and go ahead and investigate in that direction.
Okay, thank you. I think you partly touched on this, but I think it's worth just looking in a touch deeper is that a patient, here's a case capsule, that a patient with mild asymptomatic PHPT, which was incidentally detected with modestly elevated calciums and PTH, has a 24-hour urinary calcium excretion of 75 milligram in 24 hours. Would you do any further tests? How would you interpret these values? Anything to look for in a patient like this, who on the face of it looks like PHPT?
Yeah, as I said before, in this case, the urine calcium excretion is only 75 milligram per 24 hours, which is which you don't expect in a PHPT case. You expect a hypercalciuria, which is normally 4 milligram per kilogram per 24 hours is the usual thing. Generally, it is more than 400 milligrams that you see usually. This is a 75 milligram per 24 hours. Therefore, you need to do a calcium to creatinine excretion clearances and look at values. If they're normally if it's less than 0.01, probably you will diagnose a FHH. And if it's more than 0.02, then we'll say it's a PHPT.
So to the surgeons, if somehow this gets overlooked, what are your concerns if this patient lands up with surgery? Saurabh, do you want to take that question? Is Saurabh there? I thought I saw him. Saurabh, you're muted.
Yeah, 1 second. Yeah, I am here.
Yeah, great, excellent. If you could, just for that, our surgeons or our trainees understand that, what are the concerns if a patient like this without that urinary exam lands up with an operation? What's likely to happen?
So, as told already, maybe FHH. So, the PTH will remain high even if you are doing this parathyroidectomy, and the calcium will not come down to normal. That's
Yeah. So surgery would be non-curative in this
yes,
setting. Right. That's why I think it's important, especially with only modest elevations of calcium and PTH, to keep in mind, although it's rare, but to keep in mind FHH. So I have this, Garima, if you can take this question. It's a 28-year-old young healthy male with bipolar disorder, was undergoing evaluation for a right solitary thyroid nodule. The FNA from the thyroid nodule is benign. He was incidentally detected with calciums of 11.4, and subsequently the PTH came back as 120. Creat was normal. How would you proceed for his workup for hypercalcemia?
Well, I'm going to refer them to the endocrinologist. Hopefully, they can get the thing done. But yes, lithium would come to my mind in these patients that can cause this scenario. And obviously, it looks like that on the ultrasound there was just a the ultrasound was not localizing the disease, so it's going to even alert me more. Most of these patients would have 4-gland hyperplasia or multiglandular disease. And if surgery is indicated or if we have to proceed with that, then we'll have to keep that in mind and tell the patients about that. And I would still try and localize if there is any specific gland that is enlarged. I would still get a Sestamibi in these patients. I would not do any further invasive imaging or 4D CT with the risks involved, and plan for that.
So Dr. Madhu, what drugs should one? I mean, sometimes these patients do end up with the surgeon upfront with imaging done, biochemistry done, and what drugs should one keep in mind while taking a history, which could give a picture of a PHPT, which can be reversible in some cases?
I would think lithium is a vitamin D deficiency. I've already talked about. Anticonvulsants I've talked about. They're not PHPT, but at least sometimes picture calcium and PTH profiles which may be similar, not necessarily a very high calcium. A normal calcium and high PTH scenarios, they may be there, especially in the context of a normocalcemic hyperparathyroidism. It may be more important, where anticonvulsants could present with this. Lithium is, of course, the most common clinical thing which confuses, and it should be always kept in mind. Offhand, I can think of these two, but there are a couple of more drugs which are just not coming to my mind, but there are a few more drugs which are also there, but these are the two most important.
Yeah, this was actually an actual patient who had this. The patient was on lithium, and when we took it off 3 months later, his PTH and calcium actually normalized.
I'm actually currently working, Dr. Saveen, with one of the nuclear medicine friend of mine here at UAB, and we are looking at the data of how many patients because not everybody is doing parathyroid levels and calcium levels. Yes, all these patients get in the routine workup, but not the parathyroid levels. So we're working on collecting the data on how many patients with the bipolar and were on lithium. The reason it was easy for me to answer this question or this case was because about 2 years back, I had a patient who was on lithium, and he was just able to tolerate lithium and resistant. His bipolar was resistant to everything else, and we had to go in and do a 3.5 gland surgery in him. Not very enthusiastic surgery for these patients, but yes, we had to do it, and he did okay after that.
So a 50-year-old lady was detected with elevated calciums and elevated PTH while undergoing evaluation for recurrent kidney stones. She is otherwise completely healthy and kidney function is normal. She's accompanied by her 21-year-old son. On a routine health check was also detected with increased calciums, and subsequently a PTH level was also elevated. He is also healthy and otherwise asymptomatic. How should one interpret these tests, and how should one proceed with investigating the lady, the index patient, the lady forward? I would have any one of the surgeons. Saurabh, do you want to take this?
So so there is a family history here, and I think we should also looking forward to see these patients in the Mann syndrome also for that. And we have to do other biochemical test to find out if it is related to Mann syndrome, like VMA test, and also for the pituitary, we have to find out if this fits into the any Mann syndrome.
So when in your practice do you suspect somebody might be familial and start looking for familial causes? Like what would be the triggers to look for a potentially familial cause? And that's important because the surgical management of these patients can be very different, and I'll touch on that later in the panel. But when do you start looking for familial disease?
So we have to see if the patient is like, there's a very the lady came. So here is a history was there, but if the history is not there, patient is very young patient has come, and he has also a high level of calcium, you have to find out the other ways. And patients also other symptoms like hypertension and all clinical indicators which are there, which can tell you that the patient may have some other disease also. So you have to look for that. Clinical signs, clinical symptoms can lead to the diagnosis towards the from the single parathyroid disease to the multi-organ disease, towards the multi-organ disease.
Garima, your take on this question: when do you screen for familial causes? Let's assume there is no family history available and the patient has no other clinical syndromic features suggesting fitting into a known syndromic condition. So just isolated PHPT. Do you screen for familial? When do you screen?
You are muted. Garima, you are muted.
No.
So typically not. We don't screen for familial causes, especially the men and other things. But if there is a very young patient who presents with this kind of presentation, and we obviously ask family history, and if there is no family history and there is a non-localizing disease, then in a young patient with other things going on, then we do send them for the workup. And sometimes if there is any suspicion, they get that Mangement testing and other things done.
Dr. Madhu, your thoughts?
Yeah, I think somebody who presents with a non-localizing disease and a younger patient, even in the absence of family history, I think should be thoroughly screened for a familial or specifically isolated PHPT. But of course, in this case, in the index case, you have a family history also present. I think this is a candidate to definitely screen. It may be isolated PHPT and maybe screening for other endocrine diseases rarely could also bring out few other conditions. But these are the situations where you screen.
And how do you screen? Like, what is the test you like to order for these patients? Let's say we're screening for MEN1.
MEN1, primarily you have to do basically they are associated with enteropancreatic tumors and pituitary tumors. So pituitary tumors could be prolactinomas or growth hormone secreting tumors. So you need to do the corresponding hormone profiles to see if there is hyper secretion for either of prolactin or growth hormone. So for growth hormone, it would be an IGF-1 or a GH suppression, whichever is available. And of course, prolactin levels would tell you about an associated prolactinoma. And screening is not probably essential for pancreatic. Generally, they would be symptomatic. You take a detailed history of whether there's any suggestions of any insulinoma or any other glucagonoma or so on. And then because it's not that common, but then once that is there, then you go ahead and investigate them further.
Yeah. In 2012, there was a consensus guidelines by the experts. And I think as our panelists said that, I mean, of course, if you have obvious syndromic familial features or a known family history, that's a strong marker. But they actually said young patients less than 30 all should be screened for MEN1. And also they added in 2012 that people with multi-gland disease to just broaden the net of picking up familial disease, because as we see, they have to be managed a little differently. So yeah, young patients or those with multi-gland disease known pre-op are probably good triggers for screening for familial, particularly MEN1. So I'm going to move on to localizing studies. And once I finish some questions on this, maybe I can look at the chat box and see what questions have come up. I think, Garima, you already said that your favored first-line imaging is Sestamibi and an ultrasound. Saurabh, is that what you follow as well?
Yeah. Yes.
Sestamibi and
first line, yes.
First-line images. Ishita, if I can just pull you into the discussion. Sometimes Sestamibi fails to demonstrate hyperfunctioning glands. What are the clinical scenarios or causes why you may get a negative Sestamibi scan despite having PHPT?
So you get a negative Sestamibi scan in about 10 to 15% patients. The usual causes are if very small glands, multiglandular hyperplasia, glands which are in the tracheoesophageal groove. So especially when you do just planar imaging and not the SPECT imaging, you may miss the small lesions which are sitting in the tracheoesophageal groove. Also, the adenomas which are oxyphil cell poor, depleted. So there is a small segment, group of parathyroid adenomas where they have the chief cells and the oxyphil cells, and the oxyphil cells do not actually secrete parathyroid. It is the chief cells which do it, and these oxyphil cells are where the mitochondria is located, and this is where the Sestamibi goes and gets attached. So those cells, which the parathyroid adenomas, which have a low oxyphil cell as compared to the weight of the gland, may be missed on a Sestamibi scan. So that's the upper gland is often missed. It's usually the upper gland when there is an involvement of the upper gland that may be missed. The lower glands are usually picked up. So those are kind of the reasons when a Sestamibi scan may not pick up, may not be able to localize parathyroid adenoma.
Yeah, I think that's pretty much what we've seen as well, including sometimes when you have primarily a cystic gland, sometimes it doesn't show great uptake on a Sestamibi. But I think one of the things I wanted to highlight for our audience was that Sestamibi is a great test when the patient has single gland disease, but its sensitivity for multi-gland disease is actually not great. And that's why what always looks like a single gland on a Sestamibi is not always going to be truly single gland disease. And that's why we have a lot of intraoperative tools to get feedback on the adequacy of surgery. And as we go further down the panel, we will look into what's available to us intraop to help cover for this anomaly on Sestamibi scans.
Just one point I wanted to make. Parathyroid carcinomas are also often negative on Sestamibi. So that is, again, something which you just need to keep in mind, that if you have a patient with a very high calcium, very high PTH level with a negative Sestamibi scan, parathyroid carcinoma is something which needs to be excluded. Although if it's a very small 1% of the cases, but then that's also one of the things.
Saurabh, you wanted to say something?
Yeah. So last 4 years, I have diagnosed 2 parathyroid adenomas where the Sestamibi was negative on the choline scan, FDG choline scan.
We'll come to that. I have that further. So I will come to that, and we'll get Ishita's viewpoint on that. So Ishita, I have this is not my pictures. I've taken them off the internet from a case, but I'm going to put them up for you. That this is a 2D planar Sestamibi on a patient with PHPT showing 2 hot spots, one inferior on the left side and one superior on the left side. Of course, multi-gland disease is a possibility. What other possibilities would you consider? How would you modify your Sestamibi? Anything that can help sort out the dilemma between what the possibilities are here?
So if you look at the 2 scans, you find that the lower left gland is actually showing some washout, which raises the suspicion that there may be, of course, it's not foolproof, but there could be a thyroid adenoma, there could be even a papillary CA thyroid, which can take up, or even in hyperplastic in a patient with multinodular goiter, because you can see even on the right side in the early scan, there is a kind of an area of increased uptake which washes out. So typically the characteristic of a parathyroid adenoma is that there would be a delayed washout. So there would be retention of Sestamibi in the adenoma as compared to the thyroid, the kinetics in the thyroid. Now, in this kind of a situation, we need the help of some anatomical imaging. So whether it is ultrasound or whether it is a 4D CT or something, or a SPECT-CT, which can actually define where these little blotches of activity are sitting.
Okay. Great. So thyroid nodules can also sometimes pop up. And as you said, a SPECT-CT can sometimes help clarify, right? If you're looking for an intrathyroidal uptake or it's an extrathyroidal, which is more likely to be parathyroid, other than the kinetics, as you said. So I think if available, it makes sense if you have a SPECT-CT available, Sestamibi, that should be the preferred go-to imaging. So it gives you a better three-dimensional picture as compared to, let's say, a 2D planar Sestamibi scan. Alka, you do a lot of ultrasounds for parathyroids. I think your experience is now close to or over 500 patients. So what information would you like to put on your report that you think is going to be useful for a surgeon in a patient with PHPT?
Thank you. So first of all, there is a PHPT. I'll look at the clinical notes and understand whether we are looking at primary, secondary, or tertiary. Accordingly, I'll keep myself very alert, and I would try and localize, see any other imaging that's available. So I have to localize. That's my question number one. If there is a previous imaging, I can take that, but I'm not going to be biased by that. So there could be multi-glandular disease. So if there is already a localization, I'm going to confirm or refute the diagnosis. It could be a thyroid pathology, which could be mimicking a parathyroid. So I will have a detailed evaluation. I begin all my scans. I always begin first looking at the thyroid before I go to the parathyroid, because somewhere it gives me a nice baseline to understand the underlying thyroid state, ecotexture, and a baseline to compare what is parathyroid. And then I look all around, all throughout the neck for ectopic locations. I use all different transducers to localize it. Once I've localized, then I will do a 3D mapping of the nodule, like basic localization, exactly how medial, how inferior to the important anatomical landmarks the lesion is located. Then I would come to the internal character of the shape or the internal character of the lesion itself, whether it's cystic, whether there are any calcifications, whether it shows any heterogeneity or any suggestion of any calcification, whether the margin or the cleavage from the thyroid or any other adjacent tissues is clear, or is there any merging or any vascularization or anything abnormality that I suspect. And many times, like one of the things with the Sestamibi, when there's a predominant cystic change, I remember once there was hardly just a faint tracer retention on Sestamibi. And however, there was a very large cystic component dipping deep into the posterior neck, going close to the posterior spine. So communication of those findings helps the surgeon plan whether we are going for a focused miniature hole surgery, or we are planning a more counseled approach to the same. And of course, multi-glandular disease is more common than what we assume. So I think I find probably 10 to 15% cases. I think that article that I presented in ECR got published in WJOES as well. So there is a good deal of multi-glandular pathology that I find on ultrasound, which has not been documented or reported on Sestamibi. So that's another additional gain. And of course, there's been vice versa also. Sesta said so pathology is here, but sometimes that's another side.
I'm just going to interrupt for a second. I'm just going to move quickly to our surgeons, Garima. I think Alka, I'll summarize, said that she localized the gland, localized the quadrant, preferably tell you exactly where it is. Look at concomitant thyroid pathology. Give you a 3D impression of where the gland lies in terms of what depth you're likely to find it at. Is there anything else you would like on the ultrasound report? Or is that enough for you?
I think I would like to see if there is any concomitant thyroid disease that needs to be biopsied and taken care of. And another important thing that Dr. Alka mentioned, and I am very happy that she mentioned that, because I've been trying to get our radiologists to that, is to find out and define, some of the radiologists don't do that here, to define if the gland is fibrotic or cystic, or the nature of the gland. And that is very helpful for me, especially for the secondary hyperparathyroidism patients, because I want to do auto-implantation of that gland. And if I do I don't want to auto-transplant the fibrotic gland. I want to auto-transplant the most normal looking gland. So if the radiologists can do that. And some of the things we can do intraoperatively, we can figure out and see, but if it is not as helpful. The other thing is, again, it's in my secondary hyperparathyroidism talk, the weight of the gland has been used, especially in Japanese studies, to determine which patients should undergo surgery. So in Japan, people are doing earlier parathyroid surgery in secondary hyperparathyroidism, and weight-based criteria are used there. So that may be one of the reasons for the secondary hyperparathyroid patients. But yeah, for primary, I think the most important thing that I want to know is the localization and the quality of the gland and the concomitant parathyroid disease.
Yeah, one of the other things I like also is to get a sense of the size. And it's good to know that what you've plucked out matches the size of what was seen on the ultrasound, and you haven't sort of removed a normal but enlarged gland, which is just on the larger side of normal. And also it tells you what kind of incision you need. You don't want to use a 2 centimeter incision for a 3 centimeter gland sometimes. So yeah, also you said, I think if there's a major cystic component, the gland is also going to need extremely gentle handling. That's not a case to put your fellow on or put major retractors on. So I'll just share a quick slide here from Alka, and this is our experience with what the value addition of ultrasound is. And in our center, it seemed to help us localize 11% more glands than what the Sestamibi could, and also had a lesser rate of false localization. But I mean, this is not to say ultrasound is by far the best test. I think, as we would all understand, the best test is the one that's done best in your institute, at least for parathyroid imaging. And there are different favorites around the world. But what this slide says is that if we can have people committed in our imaging section who are committed towards parathyroid and stick with it for years, then the excellence just grows, and it really helps the surgeon with having a great imaging findings. Nothing's perfect, but just the better it is, the better it is for the surgeon. And again, on a meta-analysis, there is really nothing much to choose between which test is better. Generally, most centers, it seems, our panelists also prefer to do both. So I think, Garima, you had already talked about this, that we have a patient with PHPT with ultrasound negative and Sestamibi negative, nothing localized, non-familial PHPT. So I'll take this question to Saurabh. What's your next test? You mentioned choline. Is that your choline PET is your next test?
Yeah. So choline PET, yes, in this scenario, it can help because it functions differently, because it functions both in the chief cells and oxyphil cells. So yes, it can help in this case. Definitely, because these patients are not, you have not in emergency to operate these patients. You can wait a little bit because the availability of the choline is a difficult thing. And so these patients can wait for some time. When the choline is available, you can do this choline PET at that time. And definitely, I would like to do in this case. Definitely, so there is ultrasound is also negative. And I can say one thing here. Said I have worked in your institute also, and now I am working at a different institute. The experience of the ultrasonologist is very, very important. So if in my institute now, if the Sestamibi scan is negative, I would like to do a choline test. I will not believe on the ultrasound.
Yeah, makes sense. I think one should stick to what's good in their institute, and different institutes have expertise. So I'll put this question to you, Garima. I don't know. I think choline PET's not that popular in the US. It's not. I think US has moved more towards 4D CT. So, okay, let me put it to Saurabh. 4D CT or choline PET? What should be a second line test? What's your preference? I think Garima is 4D CT, she told us, and I've got some questions for you. But Saurabh, yours is 4D CT or choline PET?
No, I would like to do a choline PET.
You're a choline PET. Perfect. I think Garima already talked about the 4D CT and how it's based on differential enhancing patterns for parathyroid adenomas, and just some literature to support that, particularly when you have discordant imaging, the 4D CT can really help above and beyond the Sestamibi and ultrasound information. So Garima, have you moved towards 4D CT as the primary imaging modality? What's your thought? Many centers are doing 4D CT as the only imaging modality for PHPT. Do you see that happening in the future, or you want to keep it as a second line test for now?
Well, I would definitely keep it as a second line test. And actually, one of my senior partners is doing 4D CT on majority of his patients, so mostly all the patients, if he can get that. Because our radiologists are doing a pretty good job with that. And then he wants to capture those 4 to 5% double adenomas. But I think for this disease, which specifically if it is not as morbid and patients don't have significant symptoms or significantly morbid symptoms, I would not subject them to all the radiation. And honestly, even if they are non-localizing with a high PTH and they have a little bit of symptoms, nothing major. PTH is not terribly high, calcium is high, but it is still 10-11, between 10-11 range, then I do not get a 4D CT right away. I wait and make sure that they are off their supplementations, off their vitamin D is corrected, and I bring them back in 6 months to a year, unless obviously they are pretty persistent about getting the surgery. I bring them back in a year, do the imaging again, and if it is again non-localizing, then I do the 4D CT.
Okay, so that's an approach for patients who are essentially asymptomatic. I'm guessing not meeting criteria for surgery.
Even the patients
might be symptomatic. Let's put it this way.
Correct. Well, if a patient is symptomatic with 10 to 11 range calcium, maybe a remote history of kidney stone, maybe some osteopenia, maybe some fatigue, I can still bring them back in 6 months and do repeat imaging. And at that point, I would do a 4D CT. That's what my approach is here. Especially in the younger patients, you don't want them to be exposed to all that radiation right away.
So I think Saurabh had already brought up, and these are images. Ishita, thank you for sharing these with us. This is a case we had not localized on ultrasound, Sestamibi or 4D CT, but a choline PET showed a bright spot retroesophageal. And actually the literature on choline PET is very encouraging. It really looks like it's got a great sensitivity for patients, and mostly, remember, it was done in patients where the other imaging did not localize. But it's a small number yet, and there hasn't been that much volume of this imaging, but it looks encouraging to me. I think it's a test to look out for the future. So I will just quickly look at the chat box and see if we have any, or you know what, let me just get through the surgical part, because I think the surgeons will be getting antsy. I'm sure they want to get into these surgical details. So let's get into the surgery part and get some thoughts of the panel on that. Okay, quick 5 questions, and because I've still got a fair bit to cover, and I know Vipin is a hard taskmaster with time, but we did start a bit late, so will give us a bit of leeway. But we'll do quick questions, quick answers. So Saurabh, your thoughts on the 5 questions I have. Any preference for an approach? And the questions are up there if you could just answer them briefly, just to get a sense of where do you stand with your approach.
I assume all this parathyroid is already localized.
Yeah, these are for focused parathyroidectomies.
Okay. So for the inferior, I always have still, if there is some other things and very there, the inferior parathyroid lateral approach, superior parathyroid like midline approach. Most of the time. Routinely identification of rectal angina, no. I usually try to see if it is there in the field. I try to find, I never try to find it, but I am very careful. Sometimes I have seen that the nerve is going superficial to the parathyroid. It happens sometimes, so you have to be little careful, but you do not have to always try to find out the rectal angina. I routinely send the frozen section for excised gland. Yes, I always send. They never tell us that it is a parathyroid adenoma. But if you have a very good rapport, they can tell you that it is a hypercellular parathyroid. maybe parathyroid adenoma. It helps sometime because I always use a PTH intra PTH test. So if the second after 10 minutes is not come down to, maybe it come down to 50% only, not the 30 or 70, 80%, then you are little jittery and you just try to find on the frozen section, so they can tell you at least that it's looking like a parathyroid adenoma at least. Utilizing minimal access approaches, robotic laparoscopy, no. It's a small incision, usually most of the time 1 inch or some. If the parathyroid is smaller, then you can give little more smaller incision also to take out the parathyroid. So I never use robotic or laparoscopic. Yes, for the ectopic parathyroid, like in the one recently we have done from the mediastinum to the VATS approach, that's a different thing. Not in the neck, utilizing intraoperative always, except for the emergency cases where the time is important. I always do the intraop PTH.
Garima, you differ on any point?
Just one, I want to bring a couple of things. One, for the nerve, I actually want to ask the audience, do you guys use any nerve monitoring?
So I don't know how you can ask the audience on Zoom, but
I mean, the virtual audience.
Yeah, I'll tell you what we do. We use INM if it's revision. We won't use INM for a primary parathyroid surgery.
Well, I typically don't use it, but sometimes for the primary cases, I have actually recently started using it, and more so because I had one patient who had weak voice after the surgery, and I had several sleepless nights, and then I decided, since I use it on all my thyroids, I would use it, and it recovered. It was probably just neuroparaxia, and there was no reason for the nerve to be injured in a big adenoma. And typically, I don't find the nerve, especially in a well-localizing adenoma or well-localized adenoma. For my bilateral approaches and four-gland explorations, I do try and look at the nerve every time before I check out, especially because they are very small, small-sized or sometimes normal-looking glands. Okay. Frozen section, I was doing frozen sections before on all my patients, but then the utility dropped and it was costing a lot. And one thing I can tell you that intraoperative PTH here in US is not, I mean, I do it on all my patients, but apparently it is expensive. It costs $500 to do an intraoperative PTH. One reader.
You can probably get a parathyroidectomy in that much out here. So by the time you send 4 intraoperative PTH samples, I think you're done with the cost of surgery. All right. Okay. So here's a case capsule. I mean, you've got some interesting cases. During focused parathyroidectomy for a patient with a single gland localized on imaging, the pre-incision intraoperative PTH level is 424. And the enlarged gland is identified as per the preoperative localizing studies in the right inferior location. 10 minutes after excision of the gland, the intraoperative PTH is 325. So that's less than a 50% drop. How would you proceed? Saurabh, your thoughts on this clinical scenario?
I will send after 10 minutes as the second sample also.
So at 20 minutes you send, and that sample is, let's say 270. So again, a less than 50% drop. Look, I'm not going to get simple cases for you, right? For you, I'm going to get the tough ones.
so yes.
No, because these are practical. This is a situation any surgeon can face in surgery.
Yeah.
Inadequate PTH.
And we have faced, everybody has faced who is doing the parathyroids. So 270, it's not that low. It is not that high. It's in the midline. You are in the graph. This is a discussion. This is a discussion with the family intraoperatively. I have to do.
I thought you were going to discuss with the patient.
No. With the family. Because see, I will take out the parathyroid on that side.
That is
the second parathyroid on the ipsilateral side.
Okay.
For the contralateral side, I will wait for the final report on the next day or after some days. And if it is still high, I will try to find out. Then I will go for the second side and take out one and then take out implant the second, then it is hyperplasia. You will have a histopathology report also by that time.
So what you're saying is that even if you don't get a drop,
Complete drop.
you wouldn't proceed, adequate drop.
Yes.
You wouldn't proceed with a bilateral neck exploration in the same sitting.
No, I will not. If like it's remains 325 on the 424 after 20 minutes also, then you are pretty much sure that it is a four-gland hyperplasia, 100% almost. Then I will go ahead. But if it is almost there in the 50%, I will not send the PTH sample again and again at 10 minutes, but still there is a high chance that by the next day, the PTH sample will come down. Yeah, that's my approach in this case. If it is,
what would your thought be?
So first of all, once we send a sample at 10 minutes, by the time the reading comes back, it's already 30 minutes. So it's given us enough time. I sent another PTH at that point, and I also sent my the gland that I've excised for frozen section to confirm that I actually took out the gland and it's not a lymph node or something unusual. If the gland is confirmed to be a adenoma or hyperplastic adenoma and the PTH has still not dropped within the normal range, at this point I would expect normal range because 30 minutes have passed. And considering that the creatinine clearance of the patient has been normal, the kidney function has been normal because some of these patients could be slow excretors. At that point, I do 4-gland exploration and look at all 4 glands. And if I am able to identify all 4 glands, majority of the time, I would see another one that is a culprit. If I don't see that another one is in an enlarged gland, then depending on the clinical scenario, either at that point I would do 3.5 gland if I'm pretty sure that
We'll come to that. I think the question what I wanted to ask was that if you get an inadequate drop, based on whatever protocol you use, is what would you do? It seems like you would proceed with the bilateral neck exploration, right? That would be your approach to look for other hyperfunctioning glands. So I have one question here. Do you send one pre-excision sample? Like this patient had a pre-incision sample. We like to send a pre-incision and a pre-excision, like 2 samples. Do you send 2 samples before the gland comes out or single sample, just a pre-incision?
I just do one before even taking the patient to the OR and the pre-op, basically.
And the pre-op.
Yeah, because one patient has already had some samples in the clinic anyways. So we have kind of an idea what is PTH, where his PTH stands.
I send after the anesthesia, but before incision.
And do you send a second sample pre-excision?
No, I don't send.
So what is the advantage of the pre-excision sample?
So we send 2. The Miami protocol actually says you have to send 2, but there are protocols like you said. I think the Vienna protocol just asks for a pre-incision. Many just ask for a pre-incision, and that's to do with the kinetics of how PTH can vary intra-op. And manipulation of the gland can actually lead to increased PTH levels. It's transient because of the manipulation of the gland. And we've seen this occasionally, not uncommon, not infrequently. At times, even doubling of the pre-incision PTH just prior to excising the gland. So if we have that value, then sometimes what looks like an inadequate fall compared to the pre-incision is actually an adequate fall compared to the pre-excision. And on the Miami criteria, they say that you should take the highest of the pre-incision or the pre-excision as baseline. And we're in the process of trying to get the data out in all our cases as to what percentage had a higher pre-excision than pre-incision. But literature says it's not uncommon, and we've seen it actually more than double sometimes the pre-incision value. So we stick with sending 2. That's the way we do our IO-PTH protocols. But I thought I'll bring it up to see what other people follow. And of course, different institutes, different protocols.
Can I ask a question here?
Pre-excision is lesser than the pre-incision? Pre-excision is...
Yes, we have seen that also. And I think that may depend on the timing of when you send the pre-excision. See, ideally, the pre-excision should be sent before you clamp the blood supply of the parathyroid adenoma. But sometimes in a difficult to find adenoma, if you're dissecting, you might have already disrupted its blood supply. And by the time you find it and you say, I'm going to send a pre-excision now, the parathyroid may already be relatively devascularized and the PTH levels may be dropping. So yes, we've seen a pre-excision lesser than the pre-incision as well. Dr. Madhu, you had a question.
My question was that if we are looking for in terms of a drop in PTH for whether we have removed the parathyroid adenoma or not, this this value of a high pre-excision PTH would actually be will not favor it, because any drop would actually be a drop of what rose. It's not the baseline, you know, it's not due to the adenoma per se. It's just because of the handling that it is increased. So 50% drop or a 70% drop may not have that value. That would be my interpretation.
Literature says, I mean, my thought would be the opposite, but we can always discuss it. I think we might be short on time. My thought would be what you want to see is once the offending gland is out, in a short interval, does your PTH drop or not? And if it fails to, it means you've got another hyperfunctioning gland somewhere. But if you get a good drop, that's generally considered sufficient. And almost all literature that's looked at pre-excision values agrees that if you just take the higher of the two as your baseline, because that's where you started. And you want to see in 10 minutes if you've dropped 50% from where you started.
Okay.
Which do you have a preference for the protocol, Garima? I mean, there are many protocols for IOPTH. Which one do you have a preference for, any one or the other? Saurabh, I'm guessing you still follow the Miami protocol, except you modified it with only a single sample pre-incision. You don't send a pre-excision anymore.
Yes.
Okay.
I don't understand the what do you mean by the protocol?
So there are many protocols for IOPTH testing, you know, based on when do you send the pre-excision samples, when do you send the post-excision, 10 minutes, 20 minutes, you want 50% fall. For example, I'll give you like the HAL protocol is the most stringent. They expect a fall into normal range. They say your surgery is successful if the PTH drops, but drops into the normal range. On the other hand, the Miami Vienna protocols are basically looking for a 50% or greater drop after excision of what you think is the offending adenoma. So let me just put it this way. Do you look for a drop into normal, or are you happy with just the 50% drop?
I am looking for a normal drop. I mean, it has to be under 60. If we start with like a 300 of PTH, and if it drops to under 100, I would be happy. But yeah, I'm not, because, you know, by the time it is 10 minutes, half-life is about 2 to 4 minutes. So at 10 minutes, it should usually fall within a normal range, especially for single gland disease. If not, then I'd send another sample before.
Got it. Yeah, I mean, I put this up just to say there are many protocols. Everybody follows different ones. If you use very stringent criteria, like what you say, and which literature supports that if you look for a drop into normal range, then you're very less likely to miss other hyperfunctioning glands. However, that will always be associated with a higher rate of unnecessary explorations, because patients may not meet the criteria all the time. In India, because we often have patients starting with PTH well in the thousands. So getting a drop into the normal is not always going to happen in 10 minutes. So we actually follow the 50% drop as Saurabh does. But certainly many centers follow more stringent criteria. I think we must realize, like with any cutoff, the more stringent your criteria, the less cases you'll miss, but the more unnecessary bilateral neck explorations you will have. All right. Okay. I think this might be my last case, clinical. And this is an interesting case. So a patient with PHPT was localized as having a left inferior parathyroid on 2D Sestamibi scan and ultrasound, and a focused parathyroidectomy was done. The frozen section pathology report showed a parathyroid tissue. No intraoperative PTH, let's assume no IOPTH was done in this case. And post-operatively, the patient persisted with a high calcium and high PTH. Thoughts on the surgeons as what might have gone wrong here?
So the first is that it may be a hyperplasia case where the one parathyroid is more secreting, and that's why on the Sestamibi scan it has come up. So that case shows that the intra PTH is very important to do. Now I will wait for histopathology here to be certain that it is a hyperplasia case, looking like a hyperplasia case to me.
Garima, your thoughts on, so one is missed multi-gland disease, obviously the most common scenario.
The other, I think I would think, first of all, it showed parathyroid tissue, but was it hyperplasia or not? Or the enlarged adenoma itself was hyperplastic or not? Or was it like a normal parathyroid tissue? The other thing is it could be double adenoma. That would be my second thought, and obviously 4-gland hyperplasia with one gland picking up more technetium on the system. Maybe.
So, I mean, this is a virtual case. I've made it up. So let me throw in some more details. I mean, this is the only imaging we had. We had a 2D SPECT-CT. And let's say the size of the adenoma was about 8 mm at surgery, and the final pathology actually shows normal parathyroid tissue. But the surgeon's pretty sure he removed the left inferior parathyroid.
Surgeon may be wrong.
FHH.
Yeah. So when would a surgeon go wrong in a case? I'm telling you because we see this not infrequently.
So it's happened sometimes. So it's happened sometimes. You have to see on the Sestamibi scan. Also, you have to go into the detail. Like ultrasound is very important in cases like that. That if it is very close to the thyroid gland, it may be a superior parathyroid looking like inferior to you. And you have taken out thinking of that inferior, you are on the inferior part on the surface of the gland, and you have taken out the parathyroid. It may be the main parathyroid is still in, it is a superior parathyroid, somewhat the location is little bit inferior, but on the gland itself, and you have just missed it because you are doing a focused mini-incision parathyroidectomy.
Ishita, your thoughts?
Yeah, I mean, I would...
the culprit here.
Yeah, I would agree with Saurabh. This is one of those, and this was not I think this is not a SPECT-CT. This is just a planar Sestamibi scan. And, you know, in the olden days when we did not have the SPECT-CT, we used to say that you should always take an oblique picture of the parathyroid because that gives you the relation of the parathyroid adenoma to the thyroid gland. But now with the advent of the SPECT-CT, you actually are able to localize it much better. And an adenoma which is actually sitting behind the somewhere around the mid of the gland, or even sometimes the lower part of the gland, on an axial on a tomographic image, is sometimes a low-lying upper parathyroid rather than the lower parathyroid, which is usually lower and more lateral. So yeah, this could be a missed upper parathyroid adenoma, and the surgeon has just taken out the lower parathyroid, which is a normal parathyroid.
Yeah, I mean, this is exactly what such cases sometimes are. And we see these sometimes having surgery at an outside center. It's a unusually lower descended superior parathyroid on a 2D planar Sestamibi often gets reported as an inferior. And I think our panelists have already highlighted that they will always double check that with an ultrasound to confirm that you have the depth of the parathyroid right. Superior glands will be at a much deeper depth, as you see on this SPECT-CT here, paraesophageal. That's almost certainly a superior gland, more likely. And at surgery, the inferior gland is often more laterally placed. It's more superficial. It's above the plane of the recurrent nerve. So you may encounter that right in the beginning. And you may take that out and think that we've got the offending gland out, but the offending gland is actually the superior lying in a much deeper plane. And I think this also highlights why it's important to correlate the size of the excised gland to what your imaging showed. And you can have a normal gland which can be on the larger size of normal. But if your ultrasound showed an 18 mm adenoma, then you want to make sure what you got out is very close to 18 or thereabouts, and not an 8 mm, because that could be a missed. But this is not something unusual. We see this once in a while.
May I?
A low lying superior mimicking an inferior on 2D planar Sestamibi.
So, Dr. Sareen, only one comment here. The most of my experience is whenever the ultrasound measurement, whatever it is, usually when we take out the parathyroid, it is little bigger than 2 or 3 millimeter or half a centimeter than the ultrasound findings, rather than smaller.
Yeah,
Yes.
Alka is collecting data on that. Do you have anything to state?
Yeah, pretty similar. So because ultrasound will measure what they can see, so they will usually not underestimate, they will you will get a little bit more than what we measured, right? So it's very, and the other thing which is this is superiors are, I've often found them deeper, and another clue is to get the one is when we are measuring on ultrasound, measure in 3 planes, not just 2 dimensions. So I usually do all my measurements with a split screen image with 2 measurements of one image and another on the transverse image. So that way we have a more accurate representation of the volume and the size parameters of the gland, and you've actually taken the longest measurement. So that is one thing. And also to differentiate between superior and inferior, the tip that I use and many more that I'll be sharing in the book that is coming up, is to use the color Doppler, the vascularity, where it's feeding the which pole of the nodule it's feeding. Usually I've noticed over a period of time in the inferior parathyroid, so the vessel is probably entering the superior pole of the parathyroid nodule, and it's by gravity or by elongation, it's kind of descending down into the thoracic inlet or into the right. And the superiors often, it's the vessel I've often found eccentrically coming from below the thyroid, and it's entering at the inferior pole of the superior parathyroid adenoma. So often that gives me a little bit of a clue. And of course, if I look at the transverse plane with the carotid vessel, superiors I usually find them on a little bit of deeper plane, and inferiors I usually find them on the similar plane as the carotid vessel.
Okay.
Can I add one thing, my take on this previous case?
Yeah.
And some of you may not agree, but if I see with that Sestamibi scenario, if I see with just a 2D planar imaging, if I see a small gland when I'm exploring and I'm looking in the inferior region and I see a small gland, then I always explore in that area, especially on that side, and always look, I'm not missing anything else in that area, even though I'm violating the field. But for small glands, I always doubt the radiologist, I always doubt the imaging, and always look, since I'm already there, coming back is more painful than just looking quickly and making sure we're not missing anything else.
Great point. Yeah, there's so much variability in the size of even a normal gland that it can be tough sometimes to know you've got just a large normal one or a pathologically abnormally gland. That's a great point. So I said we had talked about screening for familial PHPT and why it's important. So here I have a case, a virtual case. Garima, if you can give your thoughts on this, that a patient with MEN1 and PHPT who's undergoing surgery, and you get you do a bilateral neck exploration. At surgery, you find all 4 glands are enlarged, and these are the rough sizes of what you kind of think the size is in situ, still in the patient. What operation would you do for this patient?
So I'm assuming that the patient is young in this case with MEN1. For these patients, if I'm very sure that the 3 glands stand out to be significantly enlarged and one is not as much enlarged, 9 millimeter, closer to or less than 1 centimeter, in these patients, I would do a 3 gland excision, and I would leave at least 1 gland, especially in younger patient. I don't know. I mean, we can take some part of it out too, but yeah.
So you'd like to do a subtotal parathyroidectomy. In other words, leave behind enough functioning tissue behind in the neck that you think will maintain eucalcemia. Saurabh, your thoughts?
So I will take out all 4, and I will reimplant the smallest one. I will not leave behind in the neck, because the blood supply can be hampered during the operation, and you inadvertently, and you don't know, and you can go into the permanent hypocalcemia. I will reimplant.
And where would you reimplant normally?
Baker radialis.
In the forearm.
Yeah.
So yeah, I think Good point. Either approach is fine. I think literature doesn't say whether A is better than B, but Saurabh made a good point that you must ensure the gland you're leaving behind is absolutely vascularized before you excise the others and send them for pathology. This has to be, you have to prepare the gland you're going to leave behind first. Once you're convinced that gland's viable, only then you should do. But you could do a subtotal or you could do that. Literature says both are equally effective. And if you have to auto transplant, yeah, we also like the forearm, because if you have to go back in again, it's easy to get imaging and see where is the hyperfunctioning. Is it in the forearm, or did you miss an ectopic tissue in the neck or a supernumerary gland? So you know what to go back and remove. What about thymectomy? Garima, for men one, do you routinely do a thymectomy?
No. I don't have enough experience to comment on that, but few that I've operated on, I especially if I find all four and the inferiors are standing out, I don't do thymectomy. And same thing for all the secondary hyperparathyroidism patients too.
Saurabh, what about you?
So same, if I find out all four, then no thymectomy. If only three are there, find three, then I do the thymectomy. And then there is a philosophy is different. Out of three, I will reimplant one.
Right. Right. We tend to do a thymectomy in all, but as you both said, that if you find all four, then the chance of finding supernumerary glands in the thymus is very small. It's less than 5%. But certainly if you find only three, then there's a 50% chance you're going to find an ectopic gland in the thymus. But nonetheless, we actually do a transcervical thymectomy now for all patients with MEN1. Just because literature says it may reduce your rates, and there is, of course, the risk of developing carcinoids in these patients later in the thymus. Quick word, Karima, your approach and tip if you have to do a bilateral neck exploration for suspected multi-gland disease. Like I'm talking technical tips. How do you approach the neck? How do you proceed? How do you try to find all the four glands? Do you go laterally first, medially later? Do you start around the thyroid? Just anything for us surgeons to learn from, like what's a good tip to localize these? Because these are challenging operations. Finding all four is a big challenge. So any tips you can share on this?
So one thing that I tell my residents all the time is so I mentioned the approach. I always do medial approach unless it's a revision case. I rarely do a lateral approach these days. I do a lateral approach if the patient has had radioactive iodine before. But the one thing is that once you're doing that medial approach, once you retract your strap muscles, you get your thyroid medially, I always look at the carotid artery. That is extremely important, and that helps you to give a sense of your depth and the lateral extent. You will never find an adenoma that is lateral to the carotid artery. It can be in the carotid sheath, but never lateral to the carotid artery. So that helps me a lot. That is one thing. And as I said, in four gland patients, I always look at the nerve, because out of those four, as you can see in this picture also, there will be some which are normal looking. And in those normal looking glands, you have a higher chance of injuring the nerve. So always look at the nerve for those patients, in those patients. So those are the typical two takes for me. And I don't do brachioradialis autotransplantation. I do stenophilomastering.
Saurabh, your thoughts?
So one more thing, I always do, even if it is looking like is a secondary, we are not talking about the secondary, even if it is secondary, I will always do a Sestamibi scan, because I just want to know which is the first one I have to take out. It decreases your anxiety during operation if you are taking out the first one correctly, and you have find out, and then I go from there, and rest of the points I agree with Garima. But I usually do Sestamibi scan even if it is a four gland hyperplasia. So.
Okay, we get Dr. Madhu. Yeah.
Sorry to interrupt you, but we have overshot by miles.
Okay, I'm happy to conclude. Anytime I had a last question for Dr. Madhu, if you want me to, I can. Otherwise, we could wrap up here. As you like. I'm happy to wrap up.
Yeah, we can have this last question.
Okay. If Dr. Madhu is still there, this was actually my last slide. I think he might have actually left, but then I'll put it to the surgeons. 54-year-old lady with long-standing PHPT, and significant bone disease, underwent a focused parathyroidectomy with adequate IO-PTH fall. The next morning, her calcium is 9 and PTH is 6. And she complains of tingling in the fingers. Just thoughts on potential causes and how do you manage this going forward?
I'm glad that you brought this case because I actually wanted to tell that earlier and I didn't get a chance when you were discussing with Dr. Arora about the workup or the preoperative workup of these patients. So all my patients get an alkaline phosphatase. If the endocrinologist has not done it, then I do alkaline phosphatase in all of my patients. And that gives me some sense which patient is going to get hungry bone syndrome. And irrespective of the drop in this case, the PTH is clearly significantly low. But if the irrespective of the drop, all these patients are started on calcium carbonate and calcitriol for 2 weeks if the alkaline phosphatase in the pre-op is very high. And obviously in this patient, because of this hungry bone syndrome kind of picture, these patients will go home with calcium carbonate and calcitriol, and then I recheck the PTH at 2 weeks.
Okay. Saurabh, how do you assess patients with post-op hypocalcemia following focused parathyroidectomy?
First of all, if the patient has symptoms.
Saurabh, your voice broke off. I think everybody else is there, but you might have frozen. I think we might have lost him. So Garima, you said nicely that that patients with significant bone disease or high ALK phos, again reflecting high bone disease, are predisposed to post-op hungry bone, and you do like to put them on prophylactic calcium, right? Is that the take-home message that you said? Okay, great. I think that was pretty much it. Just that, yes, as you said, hungry bone is the cause in people with pre-existing bone disease, but we've also seen people with long-standing disease, even if they don't have severe bone disease, but they've just had long-standing hyperparathyroidism, or they start with very high calciums. They'll develop post-op transient hypoparathyroidism because the other glands are sort of asleep from the chronic suppression, and it takes a few days for them to wake up and reach normal PTH production from those glands that have been left behind. Asymptomatic, I think you actually covered already well, so we don't need to do that. And before we conclude, I want to thank all the panelists for all the contributions. I want to apologize to the audience. I think we went over time and I could not address the questions in the chat box, which I had promised I would do. And Vipin, I'm sorry. I know you're a hard taskmaster. We went over time. I don't have a clock in front of me. I was hoping you would cut in. I'm so used to you waving those things, say 2 minutes left, your time is up, placards which are well known in your meetings. So I just went on, and it's a fascinating topic and we could talk till late in the evening, but thank you for giving me this opportunity.
It's the discussion was going so nice that I couldn't interrupt you. Such a wonderful discussion. And on behalf of the association, I thank you. I thank Dr. Deepak Sareen for excellent moderation, and he brought out the problems that we encounter day in and day out. And I thank all the panelists, Dr. Saurabh, Dr. Madhu, he just left, Dr. Garima Agarwal, Dr. Ishita Sen, and Dr. Alka Singhal. And I thank the two chairpersons, Dr. Kapil Sikka and Dr. Nishant Raizada, for moderating the first session. And our speaker, Dr. Garima Agarwal, so I would request Rahul to present a certificate of appreciation to Dr. Garima Agarwal. Yeah, our president, I request our president, Dr. Taneja, to please read it out for us.
Thank you, Dr. Vipin. And this certificate is presented for appreciation to Dr. Garima Agarwal, Otolaryngologist, the University of Alabama, Birmingham, Alabama, USA, for delivering international invited lecture on primary hyperthyroidism, April 15, 2022. Signed by Dr. Vipin Arora, Secretary, AY Delhi, Dr. Hitesh Verma, Treasurer, AY Delhi. and myself, Dr. H.C. Taneja, President Division. Thank you very much.
Thank you so much, Dr. Taneja and Dr. Agarwal.
Thank you.
So I thank all the panelists and all the participants and the audience for participating in this online activity of AOI. And we have one last session before we break up for the summer vacations. This is on Sial endoscopy on 30th of April. So we have a speaker from Delhi and Dr. P.P. Singh, and another speaker from Massachusetts, Dr. Rahmatullah Vais Ramati. He is from Harvard. So both of them will be talking on the shifting paradigm of management of salivary gland diseases. So this is on 30th of April at 6 p.m. So you're invited to join. And for other postgraduates, we are a vibrant society of 700 otolaryngologists, and for those eligible to join, you are invited to join and take membership of the AOI. With these words, I thank all of you, and we close this session. Thank you very much.
Thank you. Good night. Thank you.
Thank you very much.
Thank you. Thank you.